Hi, I'm Dr. Mike Milligan. I'm here with Dr. Mark Van Dyke of Erie, Pennsylvania, a physician at a sleep apnea course. Mark, thank you so much for being with us.
Well, thank you for having me on, Mike.
Well, great. Well, Mark is one of the co-presenters here. We're down at the PGA National Resort at Rose Neerman's course in sleep apnea. John Tucker is the main presenter, and Mark happens to be one of his very best friends. And so they've discussed a lot about sleep apnea over the last several years.
Yes.
And have some unique insights and all. Mark, tell us a little bit about, well, the first thing that you presented was the radius idea and the impact that had on how much air could flow. Tell us a little bit about that.
Well, what I have never seen in my discussions with Dr. Tucker and what's going on, anyone look at the fluid dynamics that supports the underlying science behind all this. Why does it work?
Opening the airway.
Right,
Okay.
and I was just lucky enough to take a course when I was in college on fluid dynamics and biological systems, and I knew about Poiseuille's equation. Okay. So I went back to John and I said, John, you know why this works? He said, no, what do you mean? He said, well, if you look at Poiseuille's equation, if you change the radius, the actual difference in airflow is 1 over r to the 4th power.
The 4th power, that's huge.
We showed that if you made if you took a 1 millimeter radius or a 0.9 millimeter radius and compared those two, there's a 50% difference with 1/10 of a millimeter in flow in similar length pipe, similar fluid. Yeah. So if you go to when you do that and you get a 2 or 3 millimeter change, it's huge.
By an oral appliance advancing, if it opens just a millimeter, 2 millimeters, 3 millimeters, because it's r to the 4th, radius to the 4th with the
you can
flow,
we showed
it's huge.
Right, 500% was the difference in airways between apnics and non-apnics.
Yeah.
500% difference in resistance to flow.
Exactly, difference in the resistance to the flow.
Right.
Yeah.
So that's why the apnic with a smaller airway has to work 5 times harder to get the same amount of air in his lungs. That's why they get sicker, because they work harder.
Yeah, exactly. So the oral appliances work so well simply because even a 1, 2, 3 millimeter difference in opening that airway by moving that jaw forward makes that much difference in the amount of air they can get into their lungs.
Just do the math.
Okay, super. So that was one of the interesting points that you brought up. Now, Mark, you have sleep apnea.
Yeah,
I have an appliance.
Right. I'm not a sleep physician. My passion for this came through the fact that I snore.
Yeah.
And I got moved to another room. My significant other said, if you don't quit snoring, we're going to find other arrangements. So I was kind of motivated to quit snoring.
Okay.
And I happened to have a friend. John was just getting into sleep dentistry at the time.
John Tucker.
Yes. And so we've sort of done this journey together. And every time John had a medical question, if I didn't understand it, I'd go research it in the literature. We'd talk about it. We'd work through things. That doesn't make sense to me, and then John would talk back and forth. So I've learned along with everything else, and I've attended a couple ADSM conferences, been around this whole thing, and understand now the physics, and that's where I come from. I have an engineering background. I said, why does it work? How does it work? How do you make these things work?
Right.
So I've gotten very passionate about it and kept up with this.
Yeah, okay. And so from a physician standpoint, what's the need out there for this treatment?
I think what most dentists, and I said this in my presentation, now this is my opinion, as Dr. Tucker would say, the issue is most physicians, general practice physicians, don't really understand apnea and certainly don't know about oral appliance therapy.
They have no training.
No, and it's, my son just finished medical school and he's had 2 hours regarding sleep in a 4-year curriculum.
Yeah.
And he's supposed to go out there and treat people and deal with this. Now, other specialties certainly deal with that. But the important thing is there is a tremendous need to get people aware of this diagnosis of obstructive sleep apnea and to get into treatment, because sleep apnea has so many great comorbidities. I was speaking to a dentist here at the conference, 56 years old, who had undiagnosed sleep apnea and had had a stroke 6 months ago.
There's a high correlation.
93% in one of the studies.
Wow.
93% of the people who have strokes also have sleep apnea.
Wow, that's amazing. Yeah.
So, and he just proved it to us in his case series of 1. But the point being that the dentist, seeing this patient like he can ask about snoring symptoms, because I know my friends, and I'm in a busy clinic, don't ask about that all the time.
Right. So the dental office is a wonderful place to screen these patients, to educate these patients, because it's just not happening in the vast majority of the physician offices.
At least in my world that I live in. Yeah, I think there's too much going on. People are coming in for acute visits, or they're there, but we're asking about some things, but we're not. Sleep apnea is farther down the list, and people, oh, I snore, it's no big deal. Yeah. Well, it really is a big deal if we look at why you're snoring, and if you're snoring just a symptom of obstructive sleep apnea, which is really causing you some other problems.
So the dentist can be treating the obstructive sleep apnea, or even snoring. That can be, as your
right.
wife,
Certainly.
Your wife said, that can be a main problem. But you need to know if they have obstructive sleep apnea before
right.
you would make the appliance for snoring.
As you sat here through the course, you understand that about who can diagnose and who can't
right.
diagnose.
Only a physician can diagnose.
Right, and the whole idea is you better make sure that snoring is snoring if you treat it, and make sure there's a PSG done so that we know that they really don't have, oh, they're not just snoring, they got an AHI 45, and you
right.
better be really careful. So
right.
Snoring, can snoring be treated? And I'll give you another thing I didn't say in general, those people is, I think we can no one has studied yet, if we intervene early with the snorers, do we prevent them from becoming apnics?
Apnics, maybe so. And he mentioned PSG, and that's a sleep study at a sleep center.
Right. Evaluated by a sleep physician who
right.
puts the formal diagnosis on those.
Right, and then they put the formal diagnosis, then we can make the appliance as
Certainly.
a dentist, the oral appliance. We can't make the diagnosis sleep apnea, but we need to know that it's not sleep apnea if we're treating snoring.
Correct.
So we can treat either the snoring or the sleep apnea.
Right.
Now, there was a big difference between success in the dentist's mind and success in a physician's mind. We like the little margin, we like the occlusion perfect, and we're looking at end goals and physical things that we can say is success. Different in a medical world.
Well, you heard what I said. I treat patients, I don't treat test results.
Yeah.
And if Mrs. Johnson, and we're worried about her being anemic, and she's got a low blood count, but she comes in, she said she's feeling better, am I doing the right thing? Yeah. Now, just because she isn't perfect, she isn't in the 2 stages of that bell curve of normal, doesn't mean I haven't made an appropriate intervention, I've treated her appropriate. And I have this discussion with John all the time. I hate to tell this, and dentists may not know this, but sometimes patients don't always get better,
right.
and sometimes patients don't do what you tell them. I know you're probably shocked at that thought.
Well, flossing, maybe so.
Yeah, I don't floss, and Tucker beats me up over it all the time. So the point being is, don't expect that there be some perfect number. If you drop someone's AHI from, you can only get them from 60 down to 15,
yeah.
Well, some people would say that's not completely treated, you ought to add CPAP. I'd tell you baloney.
Yeah.
From my point of view, you got him from 60 to 15, and he's compliant, and he's happy, and he's much better off. I'd rather have him wearing an appliance every night at 15 than I'd have him trying to have CPAP and only wearing it 3 nights a week
right.
and not being compliant.
Right. Well, that's wonderful information, and it's so nice having you. Is there any last thing to tell us, Mark, before we close?
I think that the biggest thing that John and I have found is, don't be afraid to talk to physicians. Honest, we don't bite, we don't eat dentists for lunch. It's really a good thing, and we're really not as mean as we sometimes appear to be when we get in interactions, because this is very, very unique, and I think you heard it. This is a medical problem with a dental solution.
Interesting.
And I don't know of any other area in the world where these two, medicine and dentistry, intersect like this.
Right.
And I think there's a role for both the physician and the dentist, and we need both players involved.
Well, Mark, thank you so much for being with us.
Yeah, thanks for having me.